Hello, I'm on live. Can you hear me? Testing, testing, 1, 2, 3. Testing, 1, 2, testing. Yeah. Are you there, Lisa? Oh, can you hear me? Because I can't hear you folks. Well, let me turn this up. Hello? You can hear me? I can't hear you. I see we have people. I can dim some. Dim some. What does pin comment mean? Milad Karampur joined. Milad. And Alan Wagner joined. But am I supposed to be able to hear people? I could go to my control panel on my computer. Don't worry about it. Am I supposed to be able to hear people? Oh, there's little Misty came down the stairs. Am I supposed to be able to hear you folks? Lisa? Keep going as you are. Don't worry about it. Lisa, no, you're not supposed to hear people. So do people write in questions for me then? Oh, here's some thumbs up stuff. Well, I'm happy to answer some questions if people have. I can tell you what's up. We had our hike. We had 13 people on today's hike. And we did a couple pretty steep hills. And then we finished around a little before noon, a little earlier. I guess we went fast today. And then we went for dim sum at the Joy Luck Palace. And we had a wonderful time, and I worked with quite a few people and used the hidden emotion technique with one of the hikers who had developed somatic feelings like her life was coming to an end, like her body was falling apart. And then it turned out she was very upset, kind of angry with a colleague who she respects a lot and admires a lot. Let me see if I can move this over to the middle. And then once she was able to acknowledge how upset she was, how angry she was, she had insisted to herself that she wasn't angry, but she really was upset. And then once she started acknowledging her feelings, suddenly all of her somatic complaints started to disappear. So where do I get questions from? Oh, it says 12 comments up here. So I'll look at the comments, or maybe those are the ones I have here already. Let's see. Up here it says comments. It says Laura Bittencourt, Lisa Kelly, David Burns, where it says 12 comments. Lisa, are people supposed to ask me questions, and where will those questions appear, or where will their comments appear? I'll smile. Hi. I wish I could see people, but I need to center my camera better. Seems I'm off to the edge. How about if I put the camera more over here? Oh, I'm more in the middle now. Okay. If we could have a conversation of some kind, it would be more interesting. I'm just doing a solo. I could dance or sing or talk about what happened in the hike and talk about your upcoming workshops, Lisa says. Well, sure. Let me turn on my Microsoft Outlook and get some dates for people. I hope you can still see me. The upcoming workshops, well, I have a talk at Stanford coming up on October 27th from 8 to 10 in the morning. It'll be kind of for the general public as well as for Stanford people, just a general feeling good talk. And you can link to that on my website and register. If you're from Stanford, it's free. And if you're from the general public, it's $40. I don't get any of that. I'm doing it for free. So that'll be kind of a general feeling good talk. I'm looking forward to it. And then I have the 3 workshops starting. Let's see, I'm flying out October 29th, and then there will be 3 cities, Raleigh, Atlanta, and Denver. So that week, probably starting, let's see, on the 30th. Yeah, the first 2 days, the 30th and 31st, I'll be in Raleigh, North Carolina, and then the November 1st and 2nd, I'll be in Atlanta, Georgia, and then November 3 and 4, I'll be in Denver with Lisa, and this is the And It's All Your Fault workshop, which will be a 2-day workshop for mental health professionals on intimate relationships and the kind of interpersonal model for helping people. And we did some of that model actually on the hike today. That's one of the common things we do on the hikes is we have a lot of people who join the hikes. A lot of them are mental health professionals, and they often have like problems with loved ones or patients or colleagues, and you know, need to use the 5 secrets, but also need to overcome their resistance to using the 5 secrets, because when we're in a conflict with someone, we sometimes kind of want to tell them off instead of using the 5 secrets of effective communication to develop a more loving relationship. And that's what the theme will be. And then I'm also excited. Well, let's see. Hi, David. Gustavo, thank you for your question, Gustavo Ayala. And I'd love to hear where you're from too, Gustavo. What do you think about common factor explanations of the working of psychotherapy? It has some, I have some positive and some negative feelings about it. It is true, if you look at psychotherapy research, that everything in the treatment of depression, that everything seems to come out about the same. I'm just looking at my eyes here. Just look strange. I'll look into the camera. Everything seems to come out about the same, and all the schools of psychotherapy in the treatment of depression seem to work barely better than placebo, if at all. And the same seems to be true of the chemicals called antidepressants. A lot of the more recent researchers are reanalyzing all the data in the Food and Drug Administration that drug companies have submitted to evaluate antidepressants, and looking at that data critically, there's not a whole lot of difference between people who receive placebos in these studies and people who receive the antidepressants. And in the past, it used to be thought, well, if we could show that our psychotherapy is as good as antidepressants, that's terrific, because we all know that antidepressants work. But now that there's question marks about the antidepressants, the data about all the schools of psychotherapy and the treatment of depression begins to look an awful lot less exciting. And what it boils down to is, in all of these psychotherapy outcome studies, you're rarely or never seeing a success rate of greater than 50%. Improvement, and generally that's not even complete recovery. And so what some people have said, oh, okay, so the reason that everything comes out about the same is because all of psychotherapy works through common factors, such as the therapeutic relationship, and that's how psychotherapy actually works. Well, I actually believe that that's a false interpretation of the literature. I've actually measured the common factor. It's the only causal study in the world literature, as far as I know, looking at therapeutic empathy and how much does this affect the treatment of depression? And I had at my clinic in Philadelphia several hundred patients, and we had data on how depressed they were at intake and how depressed they were at the 12-week evaluation. And we also had data on how they rated their therapists on warmth and empathy and understanding. And then I worked with a statistician from Harvard, Professor Gary King, one of the top stats guy at Harvard. And we did something called non-recursive structural equation modeling, which is a way you can tease apart cause and effect relationships from correlational data if you have data collected over time. And what we showed for the first time is the reason that the therapeutic relationship or therapeutic empathy as measured by the patient, as perceived by the patient, is correlated with recovery from depression is because there's a causal effect of therapeutic empathy on recovery from depression. That's the good news. The bad news is this was a very small effect and definitely not sufficient to account for most of recovery or lack of recovery from depression. If you've got a bad therapeutic relationship and someone is severely depressed, and then if you learn, say, the 5 secrets of effective communication to where you can develop a perfect therapeutic empathy with that patient in a session, you'll see a slight improvement from very severe, say, to moderately severe, but you won't see full recovery. And so my own point of view is that is one of the most important common factors, and it doesn't have a very large causal effect on recovery from depression or much of anything else. You could be the best listener in the world and have the best relationship with your patients, but it really won't cure them of obsessive compulsive disorder, a troubled marriage, severe depression, panic attacks, or much of anything. The other common factor that's mentioned sometimes is the patient's perception. It's called the therapeutic alliance, that I have the right therapist, my therapist is helping me. And a lot of people say, oh, well, that's very correlated with outcome. So lo and behold, that therapeutic relationship is, the most important factor. But in point of fact, those, to my way of thinking, are fake studies or badly flawed, because when you ask patients a question, do you feel your doctor was helping you in today's session, that's a proxy for improvement. Patients who are improving will say, my doctor's helping me. But that doesn't mean that the therapeutic relationship is causing the improvement. It just simply means you have 2 different ways of measuring improvement. One is through, say, changes in the score on the depression test or the anxiety test or whatever test you're using, and the other is asking the patient, do you feel that you're being helped? And those things are correlated because they're different ways of measuring the same thing. What my research has shown is that there's really 4 factors that are extremely important in therapeutic success or failure, and that's what TEAM of team therapy stands for: testing before the end of, at the start and end of every session, how depressed the patient is, how anxious the patient is, how suicidal, how angry, how happy they are. We have brief, accurate tests for measuring those things before the session begins and after the session is over. And that's incredibly important, as well as to test the patient's perception of therapeutic helpfulness, therapeutic empathy. So testing is one extremely important ingredient of therapeutic success or failure. The E stands for empathy. It's important, it's necessary, it's not a sufficient condition for recovery, but it's important to have a great therapeutic relationship with your patient. The thing that my research has shown is the most important, the A of TEAM, is agenda setting or resistance and motivation. And what my research has shown is that a patient's resistance and motivation is probably the most powerful variable, causal variable, if you're treating depression. The patient's motivation and subsequent homework compliance seem to have massive causal effects on recovery from depression. And then also the use of methods. I've developed 50 or 100 techniques to help patients challenge negative thoughts, such as I'm a worthless person, or I'm a hopeless case, or or I shouldn't be so screwed up. I should be better than I am. Those are the factors, and they're specific factors that have to do with recovery. So that's a good question. Let's see if there's any others here, but we're getting all kinds of cool people. Thank you for joining, and thank you, Lisa, for setting this up. I figured I would not know how to turn on my camera, or no one would be here. And my pessimistic expectations have been crushed in a very fun and positive way. So give me something else to talk about. Gildo, hello, Dr. Burns. I'm from Brazil. Okay, that's cool. Are you in Brazil right now? So if anyone has a question or comment, yes, I am from Greece. Your book, Feeling Good, had a major effect in my recovery from depression. Well, thank you so much. Now, underneath it says like. Should I click like on that? I just clicked like. Oh, and I'll click like on this one. I've never clicked like on anything before. I'm such an old fart. Here's someone from Italy. I don't understand well how social media works. Here, yeah, so that's Danielle from Italy. So I'll like you again. And Freddie from Colombia. Cool. I'm gonna like you too. I don't know what these likes do. See translation. So I'll click on see translation, and then I'll click on see original. So again, I don't know how to scroll up and down on these things. Oh, I can scroll up. I'm going to see if there's any. You're not supposed to hear us. Okay, I see that. Keep going. They will make comments, talk about what's happening on the hike, talk about your upcoming workshops. I've done that. Talked about common factors. Okay, I'm open to questions or comments. I'm so glad, Nikos from Greece, I'm so glad my Feeling Good book helped you. I'm working on a new book now. I'm kind of tongue-in-cheek entitled Feeling Great, but people seem to like the new title. But I have so many presentations coming up in the next 2 months that I haven't had time to work on my new book in the last couple of weeks. I have 5 presentations at the Evolution of Psychotherapy conference in Anaheim. That's a big event every 4 years, and there will be 5,000 people there or more, not all hearing me. There will be a lot of speakers, many of them quite famous, but that's a big event. And then I've got 2 presentations at the ABCT conference in San Diego in November. That's the Association for Behavioral and Cognitive Therapies, and I haven't presented it there in 20 years or more, and I'm going to give 2 workshops with Jill Levitt, who I teach with at Stanford, a 3 and a 6-hour workshop there. And then I'm going to give 3 presentations in the middle of November, and you can find all these on my website, at a major trauma conference in Calgary, Canada, with my friend and colleague Jack Hiroshi, who is organizing this trauma conference. So I'm excited about that. And then the upcoming one at Stanford, and then the 3 workshops in the East Coast on relationships, and a couple others as well. So I've been very busy, getting my PowerPoints and all the handouts and all these things prepared for those presentations. It's great to have so many chances to speak, but it's a lot of new presentations. I think I have 13 at least that I've been preparing here. So I'm real honored and excited to have the chance to present at all of these conferences, but it's a bit of pressure. But the hikes are absolutely the best. And man, we had 10 for dim sum. You've had that, haven't you, Lisa, with us? You went for us to dim sum, I think, when you were here. I can't remember, but it's this Chinese restaurant called the Joy Luck Palace in Cupertino, and they come around with these wicker baskets with steamed dumplings of various kinds, and it's really to die for. Let's see if there's any other questions or comments from anybody. We've got Mustafa. We've got Freddie. We've got Megan, Jennifer. Okay, I'm going to like Lisa, and I'm going to like Freddie. Boy, I'm going to like Freddie so many times. Oh, you love feeling good. Thank you, Freddie. I appreciate that. And Nikos, I'm going to like you. Danielle, I'm going to like you. And Gildo, I'm going to like you. Some people you can like them underneath, and then other people, I don't have that option. But anyway, I'm liking a lot of people, so I hope some good comes from it. Yeah, Lisa, I did a interview for the Stanford radio station also this week, and I don't know when they're going to post it, but it was one of the best, funnest interviews I've done. Labiba was the name of the woman who interviewed me, and she was really cool and fun to talk to. I love radio. I could do better now if I had some questions from somebody. I can answer a question on any topic of anything in the world. I can answer a question on anything. The answer might be I don't know, but that's an answer of types. But if there's a question about depression or anxiety or psychotherapy, I'm always psyched. And I don't see any. Lisa, how did you set this up? Okay, I guess you can't tell me because you can't talk. Is there a way that I can hear people? Do you know, Lisa? Or oh, does oversleeping affect mood and maybe depression symptoms? Okay, this is Nikos. I would say I can only give you my opinion on that. I don't think oversleeping causes mood or depression symptoms. Some people with depression have trouble sleeping and they have insomnia. A small subset of people with depression maybe sleep more due to depression, but I don't think these are causes of depression, but symptoms at most. But I don't think they're even very good symptoms of depression. If you look in the DSM-5, the Diagnostic and Statistical Manual of so-called mental disorders that the American Psychiatric Association has made up, one of the symptoms required for a diagnosis of major depressive disorder is trouble sleeping or sleeping too much. And I did a study of 178 people admitted to the Stanford inpatient unit, the psychiatric unit, so I could validate my easy diagnostic system. And I had a lot of information on these patients on depression and insomnia and all of their diagnoses. And so I looked at the correlation between trouble sleeping and depression, and the correlation surprisingly was zero. There was no correlation at all. And when you think about it, the reason for that is that many things cause trouble sleeping, not just depression. There's at least 50 causes for insomnia, like being angry or jet lag or drinking caffeine at night or drinking too much alcohol at night, then waking up in the middle of the night. Even mental excitement, being excited about some upcoming event or something, or noise in the environment, of physical pain. My wife just had major surgery. She had a left knee replacement, and she has to sleep on her back to make sure the leg is positioned properly. So a lot of things other than depression can cause insomnia. And if you go into a mall, say the Stanford shopping center, and ask people, are you having trouble sleeping? Sometimes almost everyone will give you a yes, and yet very few of those people are depressed. And that's why there's not much of a meaningful relationship between sleeping too much or sleeping too little and depression. The same goes for other so-called somatic symptoms of depression, such as loss of appetite or eating too much. Those are very non-specific symptoms that should not be in the DSM as symptoms of depression, and yet they're in there. but those are what I call non-specific symptoms. And if you get me talking about this, I think the whole DSM is pretty screwed up. That I was just reading a critique of it today, and it really lined up with a lot of my own feelings about the DSM. It's not. There's just we need some kind of diagnostic and statistical manual, and to name things and know what we mean by our names, and to be able to define things for the purposes of research and clinical work as well. But the DSM is not a very sound or well thought out document. We can talk more about that sometime if somebody wants it. Do you like REBTs and Albert Ellis? I love Albert Ellis, Malad. Sadly, he's dead now. I never knew him well, but I felt that he made tremendous contributions and was kind of underappreciated. So I always sang his praises whenever I did workshops, and the word got back to him. You know, David Burns is kind of a fan of yours, and because of that, he always seemed to like me, and he treated me very, very well. He was kooky, he was far out, he used the F word constantly, F this and F that, and he was very controversial. He was a wild guy, but he had a tremendous sense of integrity, a tremendous sense of honesty, and he didn't steal ideas from other people and call them his own the way so many in our field do. And I have had tremendous respect for him. He had the same idea. He's one of the founders of cognitive therapy, along with the feminist psychiatrist Karen Horney, who actually talked about a lot of the same themes as early as the early 1900s. And then, of course, Aaron Beck, who was for a short period of time my mentor at the University of Pennsylvania Medical School. But Ellis was one of my favorites. His REBT, Rational Emotive Behavior Therapy, was based also on the idea of changing what Ellis called irrational beliefs, like I need love to feel happy and fulfilled, and I should be perfect, and I should always achieve, and people should be the way I want them to be. He had great ideas. His way of doing therapy was somewhat bombastic or aggressive or confrontational, and the approaches that we've developed are radically different from the way he did therapy. But I always will have a soft spot in my heart for Albert Ellis. I always loved him and thought highly of him, and I'm sad that we've lost him. So I'm open to other questions. Hello, is anyone there? Or maybe I put you all to sleep, and I don't know how long we're supposed to go on, but I'm happy to take another question or two if anyone. I'm like a wind-up doll. If you ask me a question, that winds me up, and then I'll perform for you and tell you what I think. I'm humbled to have some people here, and later I can find out, Lisa, how you got this set up. Did you tell people I was going to be here? You know, this is all a mystery to me. This is kind of like a miracle of some kind, but it's definitely a great idea, Lisa. It says 29 comments up here. Should I click on one? Let's see. Oh, down here, what do you think about DBT for self-treatment of borderline personality disorder? Oh, there's another good question. Your impression about schema therapy of young. Okay, I see. I just have to scroll down. Well, there's a lot of questions here. Lisa tells about the intimacy workshops and blaming. Well, I'll take that one first, but then I'll talk about DBT and schema therapy. Yes, in the intimacy workshop, one of the themes there, the three coming up in the East Coast. By the way, the first one, which is going to be at the end, last 2 days in October, I think, in Raleigh, North Carolina. Is that what I said? Raleigh, I think. That's going to be streamed live onto the internet. And so if you want to attend that workshop but can't go to Raleigh, North Carolina, you can still register for it and attend through your computer. And if you want to attend any of those workshops, go to my workshop, my website, www.feelinggood.com. Feeling Good is one word with 2 G's in the middle, feelinggood.com. And go to the workshop page, and at your suggestion, Lisa, I moved up to the top the dates and locations and contact information for the different upcoming workshops, so you can find them easily, and then click on the link and you'll get the location, the cost, the information, the description of the workshop, and the the contact, the phone number to call, how to register. But yes, my research has indicated that one of the strongest factors, perhaps the strongest factor in a relationship success or failure is blame. If you look at people who have troubled relationships, including the people who are listening to me right now, and if there's someone you don't get along with, the odds are high that you think that person is to blame for the problem in the relationship. About 80% of people with relationship problems think it's the other person's fault. And the real problem is often the fact that we're blaming the other person. And in the workshop, I'll be talking about this dynamic as well as how to resolve relationship problems quickly by focusing on your own role, pinpointing your own role in the problem and working to change yourself rather than trying to change or blame that other person. What do you think about DBT for self-treatment of borderline personality disorder? I'll give you, Chris, a like for that excellent question. And I think DBT has a lot to offer. I haven't studied it in detail. The team therapy that I've developed was also developed for borderline personality disorder. Most people don't know that. In my practice in Philadelphia, about 28% of my patients had severe borderline personality disorder, and they were more challenging to treat and often more oppositional and more resistant. And that's how TEAM and why TEAM evolved out of cognitive therapy. TEAM is like cognitive therapy on steroids, and is much more powerful, especially at helping resistant oppositional individuals, and frequently patients with borderline personality disorder have those features. But it's DBT and team therapy, as it turns out, have a lot in common. And one thing I like about DBT is that patients are treated in groups, which is not only potentially a powerful way to help people, but obviously cost effective as well. And when I was in Philadelphia, we put our whole department of psychiatry, treated people only in groups, and we outlawed individual psychotherapy, and we had tremendous results helping the people that we served. It was an inner city hospital in a gang warfare area, and most of our people had very few resources. Many couldn't read or write, and we treated everyone in groups, and it was just a very emotionally fulfilling experience for us, and the data showed that we got tremendous results with the patients as well. The language of DBT is different from the language of TEAM, but they're often using different words to express similar kinds of concepts. Another thing that I like about DBT, or so-called dialectical behavior therapy, is the fact that there's a lot of support for the therapist as well. And I've always felt that way. I've been doing that for 35 years. I've always had a weekly support group for the therapist in my group. And at Stanford, I offer unlimited free psychotherapy training for therapists in Northern California. All they have to do is show up at the group from 5 to 7:30, and they can do personal work and learn team therapy and get help with difficult cases. And then also I have my Sunday morning hikes from 8:30 to 12. and we generally hike for 3.5 hours. And Lisa, you remember those hikes? We took the hike today into the Foothill Park, the Palo Alto Park. We did that one, but we came out via a very steep hill. But we had a tremendous hike, and on the hikes they can get personal support. The therapists need help just as much as our patients usually. And the therapists on the hike today talked about relationship issues, somatic issues, anxiety. That we did the hidden emotion model. We did the 5 secrets of effective communication. We had a tremendous hike. So I think there's a lot good to be said for DBT. And then the schema therapy of Jung, gosh, his first name just went out of my brain. But Jung was one of the earliest cognitive therapists, and when I was going to be the weekly seminar of Beck, when I was learning cognitive therapy, he was too. So he was one of the early pioneers of cognitive therapy. And then he developed his schema therapy, which I haven't studied intensely. I have to admit, but we had a Stanford faculty member who was very, very big on his work, and essentially he was trying to develop ways, and still is trying to develop ways of categorizing the thinking, the thought processes of people with personality disorders and relationship problems. And so, for example, he would say that patients with paranoid personality disorder have a schema that people can't be trusted, or people are out to get me, out to hurt me. And that's kind of a basic core belief that they carry around. And others may have a core belief in relationships that I'm helpless, and other people, I need other people to take care of me and to help me, and that would be like dependent personality disorder. And then we see some people who have the idea that their schema is that I'm superior to other people, and other people should admire me and serve me, and my needs are more important than the needs of others. That's called narcissistic personality disorder. And so I think there's a lot of good stuff there as well, and I know Jung has a lot of fans and followers. In team therapy, we work with relationship problems more individually and analytically using something called the interpersonal downward arrow technique, which in 5 or 10 minutes you can reveal accurately, find out what any individual's, what the beliefs are, the way they're setting up intimate relationships that gets them into trouble. And it's really a fun technique. We actually did it on the hike today, because one of the hikers revealed something about his personal life that he had been hiding from us on the group, something he was ashamed of. And then I gave him, I think, a lot of good help with this problem, kind of an addiction type of thing he'd gotten into. And then at one point he said that he thought, he was afraid, he hadn't told me because he was afraid that I would judge him. And so we did the interpersonal downward arrow. Is how do you see Dr. Burns? What role does he think I play in the relationship? And he saw me as this potentially dangerous, powerful, superior, mean, judgmental person. And then what does he think his role is in the relationship? And he thought his role was to be meek and submissive and inferior and weak and kind of unimportant. And then how would it feel for weak, submissive, inadequate you to have to relate to powerful, mean, harsh, judgmental David, and what would your feelings be? And then it turned out that he feels anxious and ashamed and kind of alone and scared, and also kind of a hidden anger that he's not allowed to express for fear of being squashed. And then what are the rules of these roles? We see what role he thinks I'm playing, what role he thinks he's playing, and then what rules does he have to follow to be involved in the relationship. And the rules he has to follow is he has to be very submissive, he has to please me, he has to do things to get me to like him, he can never reveal his true feelings, he has to act phony, he can't be genuine, he can't be open, he can't be spontaneous. And he thought all of that really was right on. It triggered exactly, how he was thinking about our relationship, and he found that helpful. And then once we had revealed the interpersonal schema that was going on for him, then we kind of smashed it with a technique called the feared fantasy, and it was really tremendously rewarding for me to work with him, and he said it was tremendously helpful for him as well. I just love working with people. To me, it's like magic that happens when you see somebody changing before your very eyes and going from anxiety or depression into joy and laughter and enlightenment. And that's kind of what we try to do on the hikes, and what I think that therapy is all about. Let's see, information in Spanish about feeling good. Yes, and Freddie, I'm liking you here. There's things going across the screen too. I don't know what they are, but both Feeling Good and the Feeling Good Handbook have been translated into Spanish, and they've been published throughout Mexico and South America and in Spain as well. And I know the publisher is called Ayada, Ayada. I don't have the Spanish books with me. They're upstairs. And in a future podcast like this, I could bring one down and hold it up for you so you could see the cover of it, and if you wanted to. Here's Chris. In follow-up to that question, do you plan on releasing a separate book or an update to the Feeling Good book, teaching the TEAM methodology in a self-help format? Well, first I thought I would revise Feeling Good and the Feeling Good Handbook, and both the publishers were enthusiastic about that. But to tell you the truth, when I looked at Feeling Good, it was so tightly woven. It was like a fabric that was all hanging together as one thing. And I hadn't looked at it for 40 years. And I thought that this is really beautiful, the way it is. And I don't think I want to try to take this all apart and put it back together again in a new way. And furthermore, it's still healing people. People read it. I get emails every day from people. I read your book and it transformed my life. I've been depressed for years and now I have joy. And I thought, why fix it if it ain't broken? And I just decided I have so many new ideas, so many radically new and different techniques. The old ones are still pure gold, but I have fantastic new stuff, new ideas that it would actually be easier and more fun to write a new book. And so that's why I've gone that route rather than the route of revising the old books. At some point, maybe I'll still go back and revise, say, just the Feeling Good Handbook would be easier to revise than Feeling Good. But right now I have my eyes on little bigger goals than that. So here's Lisa. Probably a good way to wrap up for this week. Are you coming back? Yes, I can be back next Sunday. Did people know what time this was or anything? Or I guess you can explain that to me, but I'd be happy to wrap up for this week. Just to thank all of you. Hi, and I used to have a severe camera phobia, which I got over about 2 or 3 months ago. I can now smile on the camera, so here's my smile, and I couldn't do that in the past. I was terrified of that, and but yes, I smiled to thank all of you for participating, and I hope you have a good day and a good week. Should I just go ahead then, Lisa, and hit this finish thing down here? And if you have any questions that weren't answered, feel free to email me. And gosh, thank you, Lisa, for making this event happen. So goodbye, everybody, and I'm going to unwind a little bit now and see if I can hang out with my beloved wife, who's recovering from her total knee replacement 9 days ago, and with our our little cat, Miss Misty, who's about a year old, an abandoned cat that we adopted as a gift from a neighbor, and then also from our elderly cat Socrates, who was also I think abandoned and multiply abused cat. He's very, very elderly and frail, but we adopted him a few years ago, and he's always trusted my wife, but he's warming up to me now too, and so we've given him, I think, a very loving home and food and tremendous love. And although he's very fearful and very frail, he seems to enjoy the love that we've given him as well. So thank you, all of you, and let me just see if there's anything. Chris says, great chat, David. Thank you. You're very, very welcome. And also, if we do this next week, if you have some questions, I love your questions. So on the count of 3, I'll hit finish. Okay, 1, 2, 3. Here goes, and goodbye. Have a good one. Bye-bye.